Our purpose of our presentation today, and hopefully the learning objectives that you will get, will be to understand how to evaluate an implant case for aesthetic results. This happens to be an aesthetic case. To learn how to diagnose the implant patient, because I think that's one of the things that us as examiners, when we are examining our candidates in implant dentistry, we want to see their diagnostic skills. Really, how are they looking at this patient and putting together the diagnosis in order to properly come up with a treatment plan. Learn the various treatment planning options, or learn some of the various treatment planning options that we'll be discussing today. Of course, there's so many. And that's what makes this implant field so wonderful. It's such a multidisciplinary field. So we're just going to present a case. I'll ask some questions about some ideas of what you have about this case, and I'll show you how I treated this case. We'll spend the next probably 30 minutes. So the patient's a 43-year-old female, so she's not too old. She's interested in obtaining the perfect smile she's always dreamed of. Her husband was recently treated in our offices, and he was a full mouth implant case with permanent implants, a fixed case. So she had that in the background before she consulted our office. And she already has a few of her top teeth that feel loose. A little bit about her dental history, because she wasn't a patient of ours. She was seeing a dentist regularly. She knows she has some missing teeth. She's had a root canal in the past with a crown on her upper area. And she was told by her dentist that eventually some of her teeth are going to get loose and fall out, and she should really think maybe about doing some implants. So that's what motivated her to seek our advice. Medically, she was healthy, non-functional heart murmur, and no known allergies. So this is the full face of the patient when she presented to us, sweetheart. At repose, you could see she doesn't show much of a smile, really. And when she does smile, we can evaluate her transition line here. So on the left, you see her in repose, and on the right, we have her trying to smile as high as she can, get that high smile line. A close-up of her high smile line can indicate that she's missing teeth and has some supereruption of some other teeth. And here's a frontal view out of occlusion. And we can see that the edge of her teeth are worn, etc. And we'll go over those findings in a little while. She's got some primary teeth still present. And here we are in full occlusion. You can see some of the complications we might have with trying to restore a patient such as this. Here's an occlusal picture of the right side that you can see, and an occlusal picture of the left side that we can view. Here's the upper occlusal view. If we walk through it, she's got some permanent teeth on the upper right, then some primary teeth and some permanent teeth in the anterior maxilla, some primary teeth on her upper left, and some permanent teeth on her upper left. Here's the occlusal view of the lower dentition. She's got some worn teeth and missing teeth. Here's our panoramic view. And on the panoramic view, you can see on her upper right, she's got tooth number 3 is present, 4 is missing. 5 is the one that she refers to with the root canal. Primary tooth in the area number 6. And then she has 7, 8, and 9. Primary tooth in the area of number 10 and 11. And then a permanent teeth in 12, 13, and 14. On the lower, she has all of her teeth with the exception of number 30 that's missing. And here's a periapical full mouth series. Look at that a little bit more closely in some of the larger images I'm going to show in a second. And I think that's one of the important things that sometimes when some of my students are sending me x-rays, it's very important to look at the periapicals also, along with any panoramic or CBCT images we have. You can see restoratively, she's really not a lot of restorative, with the exception she has this crown, and it has some decay issues on the upper right in the area number 5. We look at the anteriors. You can see her primary tooth in the area number 6, her upper C, her upper G, and her upper H in the area number 10 and 11. Tooth structure looks decent. And here's the left side. Left side does show some periodontal involvement of tooth number 14, some recession on the facial or some bone loss on the distal, but minimal restorative dentistry. And analyzing her CBCT, we can see that, again, we can see the missing teeth that she presents with, which are tooth number 4, number 6 is missing, number 10 and number 11 is missing, number 15, 16, and then down to the lowers, number 30 is missing. So we took a CBCT to get an analysis of the amount of bone that this patient has. Certainly from those panoramic views, it looks abundant, but let's take a look at the cross-sectional images. Here's the images showing areas of the upper right side in the edentulous area of tooth number 4. And if we look at that area of tooth number 4, you can see we have actually decent bone from the crest of the bone to the side is 16.25 millimeters and a 4.96 millimeter diameter. We look at the anterior images for this patient, both on top and bottom. This is the maxillary anterior cross-sectional image in the tooth number permanent position of number 6, where we see tooth retained number C, with a ridge width of 6 millimeters and 18 millimeters to the floor of the nose. And if we take a look at some of the cross-sectional images on the upper left side, we can look at images in the areas number 10 and number 11. In number 10, we have the retained G, and we have a 4.9 millimeter width, which gets more narrow as we go apically, but still 16 millimeters of length. In the area of number 11, where the permanent or primary tooth is still retained, we have a 5.1 millimeter width with a 17.24 millimeter length. So if we look at the lowers, we might as well analyze the lowers. The patient's looking at a smile changeover. In the lower area, in the area number 22, we have about 8 millimeters in width, going to 5 and a 6 millimeter width with a 29 from the crest to the base. We look at the areas in the midline, the area of number 23, where she has her worn lower dentition, we have a 5.46, getting more narrow to a 4.89 and then widening up to 9.3 with 29 millimeters from the crest or the alveolar bone to the base of the mandible. Then looking at the area of the lower right, in the area number 27, we have 4.56 going up to 8.5, 29 millimeters of width. She's also missing a tooth in the posterior right area. In the area number 30, we can see we have a 6.6 millimeter width by 13 millimeter width. So from our clinical exam, we can see that she's missing upper teeth. Number 1, number 2 is missing. This is number 3 present. Number 4 is missing. 6, 10, 11, 15, and 16. You can see that she's retained primary tooth number C, G, and H. She's also missing tooth number 17, her lower left wisdom tooth, as well as her lower right first molar and her lower right second molar. She does have some caries underneath the crown on tooth number 4, and she's got some minor caries on tooth number 7. Her occlusal scheme, she is a class 1 occlusion. And then if we examine her periodontal condition, the pocketing depth in general is minimal with 3 to 4 millimeters of pocketing. In the area of number 14, she does have a 6 millimeter on the distal buccal with an early type 1 furcation involvement. Probing is minimal bleeding upon probing, so minimal inflammation. The mobility on her primary teeth are greater than 2 on C and greater than 2 on G. So we presented some information. We can now start to get some ideas of what is the diagnosis, and I can get some participation if you want, because we have a few minutes. Maybe some of you can come up with a list of some dental diagnoses for this patient. You can chat me, or you can ask Eli, and he can relay the message. Let's see, I'm going to go to the chats. Okay. 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 Let's see. Okay. Okay. Any questions from our audience? Any chats? Let's see. Okay, so this is from this is from Dr. Young. Thanks for the shout out, Dr. Young. Chuck Town, partially edentulous maxilla and mandible. Exactly. These are some of the things that you'd like to present when you talk about presenting this diagnosis before your board exam, for those of you that are prepared for that. Maybe we could bring up the x-rays. Very good. Someone's suggesting maybe I could bring up the x-rays on the diagnosis part here. No, I can't. I'm sorry. Let's go back. I will go back and bring up the x-rays. All right. Let's see if we go back. Okay, let's bring back the x-rays. Go back to the x-rays. Let's make some diagnoses. Now we could chat. How's that sound? All right, so I have a partially edentulous edentulous man. You got hyper eruption. Absolutely, that's a very good diagnosis. Shout out to Maggie. Hope you're staying healthy, kid. Partially edentulous, excessive gingival display in the maxilla. So absolutely, a low transition line there, right? Absolutely. Ectodermal dysplasia is a possibility here. I'm not sure whether, but certainly. Something to such as malformed teeth for sure. Anodontia I see coming up. That's certainly a diagnosis. Periodontitis from Dr. Shaw. Does periodontitis? Yes, it's probably a type 1. It's probably minimal periodontitis. Retained primary teeth, absolutely, because of anodontia. This patient's retaining primary teeth. Anything else you guys like that? How about some bone diagnosis, guys? You know, I'm always impressed with those candidates that come before the board, and they give me a division of bone or a classification of bone. Anybody want to give me a classification of bone on this patient? From a chat. If not, I'll start just laying out some of the stuff.
Dr. Minichetti, I do have a quick question.
Yeah.
What was the attachment loss in general? Someone was asking.
I'm sorry, can you speak up, Eli?
Oh, sorry. What is the general attachment loss in general?
The general attachment loss.
Correct.
Minimal attachment loss. If you look at the patient's attachment, it's pretty good. She's got some recession, but periodontal bone support is pretty good. It's a very good question because we're making periodontal diagnosis. You absolutely need to make a periodontal diagnosis on this patient. Let me just see if I can go back. I'm going to go quick. Yeah, because we have minimal, there's really minimal attachment loss when you look at this patient, is there not? When you look at the periodontal health, good lamina dura bone here, minimal recession when you looked at the photographs also. So that's a very good question. Any other questions? Any other chats? I got 4 new chats. Okay, now we're talking. So we have a MISH Division B. Absolutely, doctor. Thank you, Dr. Antonella. Right, because it's narrow, but plenty of vertical height. These are things you start thinking about, because when you're thinking about the divisions of bone, you start thinking about treatment options for this Do I have a full 3D image? No, I really don't have. I do, but it's in the next slide when we're starting to diagnose. So I'm going to apologize about that. Siebert's class 1, absolutely. These are the type of diagnostic diagnoses we want to have. Not only do we have the MISH diagnosis, but we have Siebert's diagnosis 1, 2, and 3. Excellent, excellent, excellent. Okay, so you guys are on the ball. Thank you so much for being part of this. Smart group. Let me just see if I can escape for this. Sorry, I want to get back to where we were. And then we'll just walk through the diagnosis, and then let's go through the treatment plan, okay? What treatment plan options do we have, okay? Because there's a lot of treatment plan options on this patient, and I think that's one of the purposes of this presentation. We shouldn't get stuck in a treatment option just because there are options of treatment. We need to clarify our treatment options and present all those treatment options to the patient because of the diagnosis we make. So yes, caries is minimal, partially edentulous, malformed teeth, anodontia, periodontal type 1, plaque-induced, occlusion, type 1, closed bite. You could start doing Kennedy classifications on which teeth are missing. And the smile, of course, it's paramount here, particularly this is an aesthetic case. The patient has aesthetic concerns. She's got a high lip line. Her transition's low, the upper midline. So what do some of these things relate to? And then here we are with this division B, according to Mission Judy's article, and a Siebert's class 1 classification. So when we're talking about this diagnosis, it starts giving us treatment options for this patient. You know, can we expand the bone? Can we do we have enough vertical height for this patient? Because of the closed bite, it's going to be a restorative issue for this patient. Because of the transition line, should we reduce that transition line so much? Or do we have the bone to reduce that transition line so much if we decide to go with that type of therapy? So let's go over some treatment options, guys. Okay, this is where it gets complicated because we have a million here. And I mean, I toyed with it because I was going to go one way, the other way when I was treatment planning this patient. So okay. So yeah, rather than start typing, I'm just going to talk about options here. So she had no TMJ symptoms. I think there was some questions about a TMJ symptoms. She didn't present with any type of TMJ symptoms. But if you guys want to chat in a couple of treatment planning choices on how to handle this, go right ahead. I don't know if I see any new chats. So let's see, chats. Maybe I lost everybody. You guys still on? How about you, Eli? You still on? Are we still live?
Yes, we're still here.
Okay. So maybe here's a couple of them. All right, here we go. Okay, so here's a definite, like I said, the one choice we have here by Kim. She's talking about orthodontics to close the gaps, maybe open up the palate, to expand the palate, to get a wider aesthetic result, open the occlusion with orthodontics. Absolutely. Another suggestion, combined implant natural teeth, maxillary reconstruction, restore the vertical dimension. Absolutely excellent. Excellent choice by Dr. Antonella. Thank you, Dr. Antonella. Dr. Shah, extract retained primary teeth, socket preservations. Absolutely. Implant placement. Absolutely. These are all what's going through our heads as we're planning this. Can the face, there's a question, can the face support opening the bite if possible? MD ortho, mandible ortho. Yeah, sure. Absolutely. You have to test this patient if you're going to be opening the occlusion to make sure they're comfortable. But certainly this patient is overclosed, if anything, because of her missing teeth and her development. How you doing, Kimberly Yoon? Thanks for this shout out. I'm doing just great. Yes, Dr. Fenditora, thank you. Upper full arch mouth extraction with fixed detachable. This is certainly something that could be considered for this case. Absolutely, because there's a lot of aesthetic demands. Sometimes treating the case with financial concerns is a situation where we have to discuss this with the patient. These are all excellent, excellent recommendations. All right, so let me go through some of the treatment recommendations that I went through, or some of the choices. Let's just go through some of the choices I went through in my mind. Let's just extract the primary teeth and put implant placement. It's a possibility. She has such a closed bite, though, her interarch space almost precludes just that treatment. If you recall, and we'll look at it again, she's got a super eruption of her teeth on the lower that's in the way of restoring. So another choice could be primary extraction of primary teeth and then orthodontics to open up the case. Sometimes those cases are difficult to do. Some of our experienced clinicians, of course, have done these type of cases. That's ideal. Although she's got a lot of malformed teeth that comes into play. What type of aesthetics is the patient looking for? Are they looking for whiter teeth? Is she looking for that perfect smile? And I'm going to show you what we gave her husband. So she's got some kind of ideas in her head already that lead to the treatment plan choices for her. Another choice, extraction of the primary teeth, some permanent teeth, maybe implant placement, crown and bridge, opening up her occlusion. And then this is what Dr. Teodora discussed, maybe extracting all of her upper teeth and placing implants, dealing with one arch at a time. Extraction of her upper and lower teeth and placement of implant fixed prosthesis. You know, someone might look at this case, oh, geez, let's just do an all-on-4, or let's do an all-on-4. I'm not saying these things are right or wrong, but these are some of these are personal decisions and need to be discussed fully with the patient. She is 43. So, so just to review, so here is her smile. She's got a high transitional line. Certainly, if we are going to do a fixed detachable type of prosthesis for this patient, it's going to be quite a bit of reduction we're going to need to do to move her transition line. She's got an uneven gingival line. If we're doing a FP1 type of prosthesis, her gingival line is uneven. We're going to have to address that somehow. Before, after orthodontics, etc. She's got spacing between her teeth. These are her 4 permanent teeth. How are we going to restore these, either prosthetically with the spacing or orthodontically to eliminate the spacing? She's got a higher bone level on the area where she's been pounding it with the super eruption of the teeth. So it's multifaceted here. Certainly we can see that with this type of occlusion, it's next to impossible to try to properly restore this patient. So we're going to have to deal with this patient's occlusion somehow, either with the prosthetics, orthodontically, and then decide on tooth replacement, because certainly these primary teeth are on their last leg. They're already exhibiting mobility in her maxilla. Okay. So, so I'm going to start with, when I talked to this patient originally, she kind of was in the mode to get what her husband had gotten. So let me show you her husband's case. Ant is a great guy. This is how Anthony presented to me. He presented to me in the middle of treatment. He was undergoing implant treatment for his upper maxilla, and he was not happy with the treatment. He was told that he had to have some retreatment already because he had an implant failure. So this is how he presented to me. And as you can see, he's presenting with implant placement. 6 implants were placed in his upper maxilla. The treatment plan, according to the other doctor, was going to be to have a screw-retained detachable type prosthesis for his upper. On examination of Anthony's mouth, you can see we can make some diagnoses for the husband. So the diagnosis is a failing implant already in the area of number 3. There's absolutely no bone in this sinus lift type of procedure with a crater around it, and a facially placed implant that maybe we could re-angle for a fixed prosthesis after doing a diagnostic wax up if this were in the proper position. But on examination actually of this area, you're going to see that there's actually no facial bone on this implant. He also has a severe periodontitis case on the lower, unlike what's presented by his wife. So for Anthony's treatment plan, basically I discussed the treatment options with him, and I felt that the best treatment option for the upper was to complete as upper fixed detachable after removing a couple of hopeless implants and replacing them with implants adjacent to those areas, and then following up with simultaneously lower tooth removal because of the severe periodontitis on the lowers, and fixed detachable zirconium upper and lower fixed cases for him. So you could see here's his upper case, which actually I presented as part of the complication lecture that I did way back when. I think it was 2007 or 2008. I don't know when we had that Vancouver meeting. But here's his implant removal. You know, I always try to use these more conservative things or just rotate these things out if they're that mobile. I hate using those trephine drills. I prefer using 5.56s, 5.57s, get a little elevation and just rotate these implants out with a rotation tool. And then for Anthony, we placed a couple of implants adjacent to these failing implants on the upper left, and another one anterior to that failing one on the upper right. Moved down to the bottom while the uppers are healing. He was in a removable upper denture, and on the bottom, we placed some immediate implants on the lower, and finally restored him to a fixed or detachable upper and lower zirconium milled prosthesis. But for this type of prosthesis, you understand the transition line needs to be reduced if it's not low already. Fortunately, his was low already. We did some reduction on his lowers, but with the perio, it wasn't as daunting. And the aesthetics he wanted was this full white aesthetic type of case. So this is what the patients that we're presented with has in her mind. She wants this white, perfect smile like her husband's. So when I first looked at the case for this patient that we've been discussing for Kat, you know, I thought about that. Okay, yeah, we could just remove all of your teeth on the top and the bottom and give you fixed detachable and upper and lowers. But some of the concerns I had with that is the amount of reduction I would need to do for this particular patient, and also the health of these teeth. She's 43 and these teeth are not unhealthy. Her periodontal condition is the opposite of her husband's. And I felt that it might be best to retain these teeth and deal with restoring her other teeth prosthetically to give her the cosmetic results, and trying to keep the budget down too. Because in Anthony's case, fixed detachables, the price range on those are sometimes more reasonable because we're placing less implants than this type of patient where we're placing implants in tooth positions and now crowning all of her other teeth. These cases sometimes tend to cost more. And I remember that being one of the discussions. We could do it this way, removing all your teeth, or we could save your teeth, do some orthodontics. It's going to take time. She wasn't into orthodontics, and we'd have to restore her teeth anyway if she's looking for this cosmetic white result. So the best treatment plan I thought for her was to restore her prosthetically and open her vertical dimension and replace those primary teeth with implants. So her treatment plan that we decided on was periodontal treatment first, which was really minimal. Provision, some replanting skin on the upper left, but other than that, it was just prophylaxis. And then we got her into provisionals with crowns on the upper arch to open up her vertical dimension and do some occlusal adjustment on the lower right with the super erupted canine, which was sufficient enough to open up her vertical dimension. Then I did some crown lengthening. I decided to save tooth number 5. I mean, that could have gone either way. I could have removed it, made a bridge. I decided that, if I was going to do some crown lengthening for the purpose of leveling her gingiva, raising her smile transition line around 8 and 9, I would also just do some crown lengthening on number 5. And then after we established the transition line, we did some extractions of her primary teeth. And I also did remove tooth number 7. I was hemming and hawing on whether I should do that, but I thought symmetrically, her midline was a little shifted to the left. And I felt that if I removed number 7, I can kind of just move her a little bit over. I mean, that could have gone either way. I still wonder whether I should have done that or not. And when I removed these teeth, I did some socket preservation, bone grafting, implant placement on those teeth that were missing on her maxilla. And then we just did some crowns on the uppers and some veneers for her lower anterior teeth to keep her in a budget here and still kind of give her that white smile. When she smiles, she feels like she's going to be as aesthetic and white, as her husband at this point. So, so we did some planning on these cases, and yeah, the bone is exactly, it's a Siebert's 1 or a Mish B, and it's narrow, but with some bone spreading or bone manipulation, this certainly can be managed, where we can put some implants in our prosthetic positions and align her and actually shift or widen her smile because her primary teeth are actually more spaced out. So from a diagnostic wax up with opening up our vertical dimension, we had provisionals made, and that was really the first step, was just to prep and provisionalize her in some general dentistry form or prosthetic form and get her into a more aesthetic position that can help us now as a guide before any of our implant surgery. I've actually I kept her primary teeth at this point, so we could maintain her vertical dimension. And then one of these treatment plans that I had was to raise her gingival level on the area of number 8 and 9, so we could do some crown lengthening to move her transition line. Because if we recall, the area of number 5 was, number 6 was damaged due to the occlusion of the lower, and I extracted tooth number 7. So it evened out or leveled out her transition line. Once the transition line was established with the provisionals, as you saw, we did the extraction of tooth number 7 and the primary teeth and some minimal bone expansion with a flapless technique, indicated for a division B maxilla, and then placed our implants. And then I actually utilized some temporary abutments and relined the provisionals on the temporary abutments and did immediate load for this type of case, full arch provisionalization splinted, and allowed that to heal for several months before taking some soft tissue impressions. So this is while she's healing a few weeks after implant placement. You can see a couple of suture lines still here. And we allowed this gingival level to heal, and then we played with it a little bit with the acrylic because, again, she has a little bit of discrepancy in the position of 6 and 7. It's a wide dimension compared to number 10 and 11. So once we let those implants heal for about a 3-month period, at that point, I removed her temporaries and started taking impressions, transfer impression technique for her permanent abutments. And then from there, constructed permanent crowns with the crowns on her existing teeth. And tried to keep it to a minimal position from tooth number 3 to 13. That's where her smile exhibits her cosmetic looks. And then on the bottom, we did some veneers to match that. So we made some custom milled abutments and inserted them in. And if you look at the final prosthetic results, what we ended up with was crowns from tooth number 3 through number 13, and implant replacement in the area of number 3, number 6 and number 7, number 10 and 11. And we use cementable crowns on these abutments. And there's a final outlook probably a few months later, 4 months later. And that's the final prosthetic result. And it seems to have achieved, and to be honest, the cost of this treatment ended up being a little bit more than what her husband's was, just when you start adding up the crowns. And I remember having a discussion, why is it more, why is it more? Well, it's just a little bit more, but it was more because I didn't have to put as many implants on her husband for full upper. He had some of the implants already. And but she was quite pleased with the aesthetic result, as we were. She's given us the liberty of using her full face photographs for marketing purposes. So here we are. So yeah, that's kind of it. So that's how I handled this case. Again, could have been a lot of options here, but this seems to be one of those cases that I was perplexed. I was almost in the realm of that. I'm just going to extract all her teeth, give her this screw detachable. We're so stuck in that mode of treatment that we kind of had to think outside the box to do conventional crown and bridge treatment again. So I can go through some of these questions that are coming through. So transitional removable prostate to determine implant positioning for the management, very poor treatment planning. I'm not sure what that's referring to, but transitional removable prostate to determine implant positioning. Do you retrieve a failing implant like that from the sinus was a question. I'm not sure if the implant is floating or lost in the sinus, you'd have to perform a colon. That was basically just removing an implant from the crustal position that it was positioned in. Another question, why so many implants? Well, we did individual implants per tooth because we kept the patient's teeth. There's certainly another treatment option would have been to put, all on 4, but I don't know if I would want to present that as the first treatment option for this patient. Thank you for a couple of compliments on the aesthetics on this. Yeah, so I want to thank you all. Are there any more questions? Because I hope I checked them all in the chat. Hope I didn't miss any, but if anybody has any questions, I guess we can ask Eli to come back on to answer anything.
Right, yeah, I don't see any. Oh, the other one just came through on the chat. Why didn't you use ortho to close lower spacing?
That certainly could have been an option. I did discuss with her ortho, and then it started adding extra costs. That's why we just did the veneers for her. Certainly. There's another question about, do you prefer using PRP? PRP. That's from Radhika. How you doing, Radhika? PRF possibly. I mean, I do some PRF. I did not do PRF with this case. Simple implant placement. Certainly, if you wanted to incorporate that with your flap, I guess you could. Can you explain the transition line again for your provisionals? From Christina. Okay, so sure, I'd be glad to explain the transition line. I think I'm going to escape and go, if I can, go to that slide. Maybe we can illustrate it. Okay, let's go look here, because we could certainly look here. I mean, so when we're evaluating these cases, I mean, that's one of the things I always ask my patient, smile as wide as you can. And when I'm looking at this transition line, any type of aesthetic restoration, whether it be crown and bridge or implants, if I have a gingival line that's this high in the area here of number 6, it's actually between number 6 and number 7. That's how complicated this case became. How could I possibly just put like laminates or crown and bridge and have this long tooth here, unless I'm going to add pink gingiva and have a gummy smile going across? Another consideration is to do crown lengthening on these type of cases in order to raise the gingiva line so it mirrors the lip line upon smile. It's so important in any kind of cosmetics, whether it be implants, whether it be crown and bridge, or veneers. You have this roller coaster transition line. I mean, if the patient didn't show any gum at all, it's a different story. But that's not the case here. So this patient's got a gummy smile when she smiles. You have to take that into fact. Either you're going to raise it to even it out. You're going to try to rebuild this. Good luck with that, trying to get vertical height here. So it's much easier to do excisional surgery and do crown lengthening. And that's exactly was the most critical part of this type of case, to do the crown lengthening from here. Here's no crown lengthening, and then to do the crown lengthening, and then to try to just nurture these tissues with some adding to the provisionals when you could after the healing to allow them to heal. This is early on. I don't have all the steps on this case. I apologize for that. I kind of go from the transitionals to the finals, but that's important in establishing an even gum line so it mirrors the patient smile line. Okay. Any other times? What implants did you use and could you show the CBC again? All right. When they placed immediate loading or after? Okay, the provisionals were placed first. Okay, so the first question, let me address that, and then maybe I'll show the CBC. So number one, the provisionals I used were the same provisionals. I would certainly get another set of provisionals, but I got this first provisionals to open up the occlusion without any surgery. Then I did the crown lengthening and relined the provisionals. But the provisionals were, if you notice, they were laid out. I kind of measured it, so they were overlapping till I went to reline. It was done before, trying to save some expense without 16 sets of provisionals here. And then I did reline the provisionals on to the implant. So when I'm asking the lab for the provisionals, you can get either all abutments, so later on you can reline it even if there's a pontic space. Don't have them put wires in the middle of your pontic space and your lab process provisionals. Or when I'm doing an immediate implant, sometimes I'll have the patient tunnel or trough the provisionals for these crown and bridge type of cases. This ended up being an FP1 type of prosthesis, if we're looking at the classification of treatment here. Yeah, that's it. You too, Maggie, stay healthy. Please, keep smiling, kid. Let's look at, I gotta click out of here. Somebody want to see the CBCT again. I'm not sure why, but so I mean, I could show you the CBCT 3D image showing implant positioning in the proper prosthetic position, corresponding like distal to tooth number 7. That's why I decided to extract it, and mesial to that primary number 6. This space on the upper right was much wider than the space on the upper left. So that's why I decided to extract number 7, just to kind of make this more symmetrical. Again, there's a lot of options in treatment here. I'm not saying this is the only way to treat this case. Just happy it came out the way it did. And the patient's happy. That's numero uno. Numero uno. Any more chats? Let's see. Thank you for sharing. You are so welcome, Radhika. How did you index the implant placement? I don't know if you're talking about indexing for prosthetics or indexing implant placement. I mean, the surgical guide, I mean, certainly you could make a prosthetic guide, make a clear suck down of these temporaries, but I'm basically just using the provisionals here as a guide, because that's why the case was already provisionalized. And we have positioning from the teeth that we're removing because it's an immediate implant placement. So that's how I indexed this patient. This is basically immediate implant placement. How did you deal with the inclined occlusal plane of 32? I don't think I even dealt with the occlusal plane of 32 because I opened up the occlusion. And I think that was not a problem at all. I don't think that tooth is in occlusion. I'd have to look at the x-rays, but it was a negative factor. I don't know if I even did the implant on number 30 yet on her lower, or I may have replaced number 30. Yeah. How did you deal with the inclined occlusal plane number 30? Okay. And that's it. All right. Thank you, guys. I really appreciate it. I really appreciate it. I'll go back to the last slide because I just want to show my grandkids. I mean, that's the most important slide here. It's all about being safe, guys. I mean, I really miss these kids, but we are doing our part. Let me go down here. Click, and we are doing our part to stay safe. So they're at their condominium with my daughter, my son, the neurologist, who's been at NYU. So we pray for all these people who are on the front line. And I will want to thank you guys. Just be safe, be healthy. And we are a team, and we have to stick together. We will come together again. Trust me. God bless you all.